I gave the plenary keynote address at the German CLL Study Group meeting this year, and I kind of opened it up with, I wrote a review for Blood on how I treat CLL just in 2010, so this decade, and used the first few slides to show that it was completely out of date in a very short period of time. And that's a measure of just how much this field has moved on. I then kind of in my next slide showed where we are today in terms of a much more targeted approach for individuals based upon their frailty, their P53 mutational status, the length of remission that they had to the last therapy. And of course what we've spent the last 2 days at the German CLL Study Group meeting hearing is the huge numbers of studies that are ongoing looking at finding the right combinations of therapies. So what we've got is a large number of agents which have just been approved. There's 5 of them that have just been approved within the last couple of years in CLL. And we're still in the stage of trying to figure out what's the right order in which those agents should sequentially be sequenced, what's the right combination for them to be brought together, if that's what we should do. And we had a lot of discussion about whether the right approach would be to use agents together in combination, or whether we should sequence to try to get a 5-year remission with one followed by a 5-year remission for the other. The consensus seems to be that unless or until we get to a point where using these agents in combination can get to a point that we can get a patient into a very deep remission and stop, that potentially sequential treatment might be the way ahead. In which case it comes down to, is there any data that tells us in which order they should be sequenced? In many respects, at the present time, that's happened by the order in which those agents were approved. So right now, it would seem that, in the US certainly, a lot of upfront ibrutinib perhaps being people's drug of first choice for salvage therapy, and then venetoclax moving afterwards when people have ibrutinib failures. Just because that happened for historical reasons doesn't mean that that's the way the field is going to go forward in the future. And what everyone's trying to do is how we can look mechanistically to try to identify which is the right drug for the right individual. And there are a whole variety of ways in which there's exploratory studies going on in all of these trials, looking at molecular markers of can we identify signatures who respond particularly well to one therapy versus another. In 2016, those are all clinical trial questions, but the speed with which these new agents have come in and replaced some of the old therapies we had has been almost overwhelming. And I can only imagine that for people that don't kind of sit and think about CLL for a living, it's almost how on earth do you keep up with the speed with which the field is evolving? But I think that's where the field is going in the next few years.